Adapun saat ini sudah terdaftar 30 peserta. Sekarang ini adalah sesi perdana dari 4 sesi yang kami rencanakan dengan 3 pembicara. Di era di mana penyakit kronis dan degeneratif sedang memuncak seperti saat ini, di mana usia tidak selalu menjadi faktor risiko bagi siapapun untuk didiagnosis dengan penyakit terkait usia seperti penyakit jantung, autoimun, kanker, dan sebagainya. Kedokteran fungsional dianggap sebagai alternatif atau komplement atau pelengkap dari kedokteran konvensional. Dari pengobatan yang kita kenal, yaitu kedokteran konvensional. Kedokteran fungsional merupakan pendekatan pengobatan yang integratif, jelas, berbasis ilmiah. Jadi kalau tidak berbasis ilmiah, belum bisa dimasukkan dalam kedokteran fungsional. Dan dinamis. Kedokteran fungsional ini dipakai untuk menilai, mencegah, dan mengobati penyakit yang bersifat kompleks. Sehingga bisa meningkatkan kesehatan dengan berfokus pada berbagai aspek, seantara lain adalah aspek biokimia yang unik pada setiap pasien. Jelas ini merupakan pendekatan individual dan berpusat pada pasien yang memperdayakan pasien dan praktisi untuk bekerja sama dalam menemukan akar penyebab sebuah penyakit dan meningkatkan kesehatan yang optimal. Saya katakan sekali lagi, ini berpusat pada pasien yang memberdayakan pasien. Dan juga praktisi, tetapi pusatnya atau fokusnya adalah pasien. Jadi bukan dokternya. Dengan memahami dan menemukan akar penyebabnya, ketimbang hanya sekedar mengatasi gejala, praktisi akan lebih berorientasi untuk mengidentifikasi kekompleksan dari sebuah penyakit dan merencanakan perawatan pasien dengan menargetkan manifestasi penyakit yang spesifik untuk setiap individu. Sebagai asosiasi yang sangat mendukung pendekatan pengobatan fungsional, Aksara mengadakan Functional Medicine Weekend Seminar and Workshop untuk dokter umum dan spesialis mengenai pendekatan kedokteran fungsional dalam praktek sehari-hari. Di acara ini, para ahli akan menunjukkan bagaimana pengobatan integratif dengan pendekatan kedokteran fungsional yang akan sangat bermanfaat dalam menangani suatu penyakit. And for Dr. Torsak, welcome, and we highly appreciate your presence and the time you spend here with us to share your expertise in changing the way we do medicine and the medicine we do. Our audience here not only medical practitioners, but also some esteemed patients that are already familiar with functional medicine approach and had been in long-term relationship with us in their health journey. We also have medical students. There's less college participants than we expected, given the chosen experts such yourself that we thought of as speakers. But I think you would understand that it is our common struggle to actually change an older common practice in medicine. We just have to do it often and hope you would be part of us again in the future. Without any further ado, I will pass the floor to you, Doc. Thank you very much.
Thank you so much, Dr. Aris and Dr. Sarah, to have me here. It's my honor.
Yeah, it's our honor, Doc. Maybe I should read the shortest version of your CV first, so the audience know who you are.
Yes, please.
Right? Just a little bit for those that who never heard about Dr. Torsak. Dr. Torsak is based in Thailand. He graduated from Chiang Mai University Medical School, and he had a master's degree in diet and nutrition toxicology. He continued his learning journeys until the accreditation as first Institute for Functional Medicine Certified Practitioner in Asia. He is currently has a active clinical research under the program of Doctor of Philosophy in Human Nutrition at Mahidol University, Bangkok. And his extensive clinical experience convinced him that the conventional medicine approach is only best at helping patients with acute conditions, while it is less effective in treating chronic illnesses. Care for chronic conditions essentially requires an understanding of the long-term underlying pathophysiologic imbalances that lead to the current clinical presentation. This is currently ignored by the regular practice of acute care medicine, and due to that, Dr. Torsak has supervised the personalized lifestyle intervention for chronic illness patients around this Southeast Asia region since 2003. He is one of the founders of Thailand Institute for Functional Medicine and holding the position of Director of Medical Education until now. He is also the founder of BBH Hospital. BBH Hospital is a Better Being Hospital, which is the first functional medicine and rehabilitation centers in Thailand. And he is currently providing consultation to private hospitals in Bangkok and serving as a guest lecturer at several universities. I think that is the shortest version of your lengthy curriculum vitae before I give back to you the floor, Doc. Right? Thank you very much.
Thank you so much, Dr. Sarah, for your kind introduction there, right? And hello, everybody there. Actually, my presentation, I have recorded my presentation there. So next, I'm gonna share the screen and share you my presentations. And I'm gonna leave room when I finish my presentation for any question that you guys may have. Without further ado, let's start with the presentation.
Yep, Dr. Lisa will help you there.
Hello there, I am Dr. Torsak from Bangkok. Hope everyone is doing good amid this pandemic. I am going to present the introductory topics of functional medicine practice in clinic. As you can see here, the slogan changing the way we do medicine and the medicine we do. This is quite a big word card. Let's see what you guys gonna think after I finish my presentation. We need to start with the introduction of Institute for Functional Medicine, or IFM. Jeffrey Brand, who is the father of functional medicine, coined the term functional medicine and started the institute in US since 1991. IFM organized the training course for medical doctors, naturopaths, osteopaths, nutritionists, dietitians, nurses, and other healthcare practitioners since then. For me, I first involved in the IFMCP, or 5-day of applied functional medicine in clinical practice course in US on 2006, and regularly continue with the meetings and training course of IFM since then. That concept made me realize that there are a lot that I need to study more. That was enough to drive me back to the university for the graduate degrees of dietary and nutritional toxicologies, and follow through with the current research degree of nutritional science. I'm among the first batch of practitioners that get involved in develop the APM, or advanced practical modules of different topics, to ensure that if someone has been recognized as a certified practitioner of IFM, they will be well around with the essential background knowledge. The first batch of IFM certified practitioners was approved in 2013, and I am among this group and the first one from Asia. Since then, up to this month, the list of certified practitioners around Asia is still not that long. Fortunately, I recently see one from Indonesia, while Thailand number is remaining at the first and only one. However, if you look at tons of people saying what they are doing this day, it is uncommon to see that one that claim that they are practicing functional medicine. Despite that, if I may say, these presentations on functional medicine is coming from the one with the first-hand experience in this concept. About me, I'm practicing as a medical doctor since 1989. I love cooking and get a diploma degree on French cuisine. My master degree was the dietary and nutritional toxicology. That's qualified me as an toxicologist. I'm pursuing the research degree now on human nutrition. I'm regularly publish my research on the international peer-reviewed journals. Here's some of my recent publications on 2020. Last year was quite a prolific time for me as I collaborate with a number of my colleagues and my friends and submit a certain number of articles which got accepted and published in this year. Most of my interest is on the nutrition, toxic exposure, non-communicable disease, and neurodevelopmental disorder. As with the COVID-19 pandemics, I also have 3 publications this year on the individual risk management, micronutrients, and neurological aspect of this popular SARS-CoV-2 infections. Let's start with the outline of this presentation. I am going to start with the background of why the medical practice in the 21st century need to incorporate the new models of data management to deal with the pandemics of non-communicable disease. I then am going to discuss the proposing data analytic models called the inclusive analysis, its principle and the background knowledge, and introduce the practical tools of functional medicine approach in clinical setting. I shall provide some implementation example as a few case example and the clinical setting of this approach. After that, I shall let it open for any questions or query anyone may have. We shall start with the current models of data handling in our clinical practice. We collect the information from our patient chief complaints, present illness, physical examination, laboratory testing, and coming up with a list of possible conditions called the differential diagnosis. We then deduce the final diagnosis from all these lists, most likely by excluding the irrelevant information from the probable list that we made. This model of deductive reasoning is an essential skill in medical practice, which provides us the diagnosis that lead to the best treatment guideline, predict the prognosis, and help communicating with the patients and other healthcare practitioners. This excellent model was first introduced by Sir William Oslo, the Canadian doctor who was named as the father of internal medicine since early of 20th centuries, or almost a century to this day. With this model, we drastically reduce the death from acute infection, trauma, heart attacks, and many conditions, together with the full gear development into the modern sophisticated interventions of modern healthcare as we are seeing today. However, we are completing the first 20 years of the 21st century. What we are seeing now, of course, conditions like infection, trauma, or heart attack are unlikely able to kill us all. But as the former WHO Director General called in her report, our worlds are facing the slow motion disaster in the form of global burden of chronic illnesses, which their prevalence are increasing despite the modern advancement of medical technologies. Why can't our modern medicine deal with this concern? One of the major illusions in the current models of clinical approach is the causal reductionism. When we put our effort to deduce the final diagnosis, we drift into the causal oversimplification or a single cause illusions. With one correct final diagnosis, we habitually exclude other conjoint possibilities. While this cross-sectional diagnosis is true in acute conditions, chronic illnesses or all our health and well-being are generally spanning through a continuum of full functional wellness, mild symptoms, subclinical signs to a clinical stage. This continuum of health takes decades before the clinical diagnosis. These are from my recent publication in Current Medical Chemistry, Critical Reviews in Food, Science, and Nutrition, and another one is under the review process of the same journals. The continuum of pathophysiological processes. The modern day human generally adopt the unhealthy lifestyle, which are characterized as the disrupted metabolic tempos, in terms of prolonged eating times in a day, with all the day availabilities of high calories and low nutrient diet. These preliminary conditions lead to the metabolic inflexibilities with dependency on one type of metabolic fields, which is the glucose, while ignoring other fields such as fatty acid and ketones, and anabolic promotion in long term. Adipose tissue expansion comes to the point of maladapted fat with hypoxic inducible factor expressions, local adipose inflammation, which lead to the point of downward clinical progression to almost all possible non-communicable disease, including diabetes, hypertension, inflammatory disorder, cognitive dysfunction, and cancer. To reverse these illnesses, we need to understand the underlying pattern that lead to the present situation. Of course, the diagnosis of specific conditions such as diabetes, hypertension help us to manage the blood sugars and the blood pressure to prevent further complications. However, we definitely cannot overcome these illnesses without the reversal of the underlying pathological process. In this article, I propose the comprehensive dietary intervention in terms of time-restricted, dietary-restricted, and calorie-restricted to deal with the primal cause of this disease. You can check this reference if someone is interested to know more. It is quite obvious that one final diagnosis may stem from many underlying imbalances, and one imbalance can probably be the underlying pathological process of many clinical diagnoses. Deductive reasoning to get the final diagnosis is important, but it's not enough to help us understand the whole pattern that lead to the present situation. What should we do then? The Institute for Functional Medicine has proposed the inclusive data handling model for chronic health conditions. We need to include all possible data of the patient into the analysis. These data are the present illness, past illness, the lifestyle factor, the dietary and nutritional data, the environmental exposure, and the occupational exposure, including the family data. This data analysis model is then expanding in contrast to our conventional deductive reasoning models in acute care situations. I must emphasize here that there is nothing wrong with the current way of approach, but it obviously works best in acute care situations, while the inclusive data handling may be more appropriate if we need to see the underlying pattern and design the comprehensive way to deal with chronic illnesses. With these inclusive models, the treatment will not be limited to the medication and the interventions. They may include the dietary, the lifestyle, occupational and environmental modification. It may involve the mind-body management. The treatment will not be limited to a standard clinical guideline, but it rather needs to be customized more to an individual needs and belief and lifestyle. When we include all data into the models, big data is a buzzword for it. The problem with big data is it is too many information. The research findings, the patient file, the history-taking data, the laboratory findings, the genomics data, the wearable device output such as sleep, walking, or even the 24-hour glucose monitoring data. However, we all agree that the more data that we put in, the better we can tailor our recommendation to best suit an individual. This study reviewed the example of using big data to get the output of many possible recommendations in inflammatory bowel disease. When we work with multi-models data, we usually think about the algorithms that run through the computerized neural network. These high-performance medicines might come someday in the future that converge the artificial intelligence to human health. But in our daily clinical setting, when we are facing with patients without these high technological support, how can we use this inclusive data analysis to deal with the incoming flux of clients with chronic illnesses? The world of artificial intelligence is moving fast, and many AI platforms are releasing to serve different purposes. This discovery AI platform integrates all big data to get the output that help to predict and warn for potential clinical outcome in hospitalized cancer patients that follow the standard treatment protocol. This implies that applying the best clinical practice guideline to patients with similar diagnosis, there are some underlying factors apart from the disease itself that can make the treatment output come out to be what we are not expecting for. This is another study that used serial tumor biomarker and algorithm to predict the dynamic and continuous risk for an individual. It's used in erectile individual clinical management of patients at risk for Alzheimer's and dementias. However, this inclusive analysis is done retrospectively with the help of computerized algorithms. Nothing yet serves our day-to-day clinical practice. Let's look at the situation in our clinical settings. We decided to use the inclusive data analysis for the clinical data of symptom size, lab, diet, nutrition, lifestyle, environmental, and occupational exposure. We need an analytical model to process this data to get the output that we want. Before we set up our analytic model, we need to define our desired output. As a different output requires a different analytic models. The word demand-side management is used in electrical generation business to determine the proper amount of electricity production to serve the demand of business and other customers. However, we can adapt this concept for healthcare management. What is the demand of the patients with chronic illnesses? That comes to the consensus of the ideal 21st century healthcare output, which is the personalized lifestyle management through diet, nutrition, lifestyle modification to deal with all the chronic diseases. Almost all chronic illnesses are stemmed from the unhealthy lifestyle. This is another study of the introduction of an individualized nutritional recommendation to patients with type 2 diabetes. After a period of 10 weeks, there were significantly change of the blood parameters such as HbA1c and the number and the dosage of medication that are needed to control the blood sugar levels. Some even reported the discontinuation of certain medication in this study. Even a day-to-day lifestyle, such as sleep qualities, also mean a lot to chronic conditions, such as Alzheimer's disease. This study showed that there are the rhythmic wave of cerebrospinal fluid flow during the deep sleep, which may contribute to the clearing of toxic amyloid proteins. Of course, diet, food, nutrition are the key modifiable lifestyle factors, but other factors such as sleep qualities or exercise are significantly contribute to chronic illness management. It is then a protocol of lifestyle management, not a single intervention, medication, vitamin, hormone, or herbs. As the concept of lifestyle management is advancing, we start to see the success report of some hard-to-handle illnesses, such as cognitive dysfunction. We do not have the effective drug for these conditions. The current available medications are not effective and cannot change the cause of illness. The group of Dr. Dale Bredesen, an American neurologist, adopted the approach of lifestyle protocols and reported the reversal of cognitive dysfunction in this patient. There are newer reports of more patients that successfully recover with more confirming cognitive and laboratory assessment. You can search for this publication with the name of Dr. Bredesen as an author or a co-author of this exciting development. Here is my publication on COVID-19 this year. We reported that the individual metabolic status is the key determinant for the fate of COVID-19 from asymptomatic mild to life-threatening symptoms. The important factors include diet, nutrition, age, sex, lifestyle, and environment. individual risk assessment and risk management is then the key to protect us from the consequence of SARS-CoV-2 infections. All this information supports the output of chronic illness management that targeting at the personal lifestyle modification. This practice is sometimes called P4 medicine, which is the abbreviation for the predictive, preventive, personalized, and participatory medicine. You can see the digital revolution and the system biologies or system medicine in this model of P4 medicine. This big and inclusive data nature of this concept align with the inclusive data models that I have mentioned earlier. We here conclude that in the models of chronic illness care, we need to use the inclusive data analysis to handle the clinical big data, and we should set the output for personalized lifestyle modification protocol. We then need to set up the suitable data analysis model that can be used in clinical setting without the support of computerized data management algorithm. Institute for Functional Medicine has proposed the functional medicine approach that offers the method and tools for inclusive data analysis in clinical setting. Before we go into the practical approach of functional medicine, we may firstly need to look at the principle and the foundation of this inclusive data analysis model. Like all mathematical models, we need to set up some parameters before we can run that model and get the results. The inclusive data analytic model needs certain principles and foundation to effectively analyze clinical big data. In this article in the Journals of American College of Nutrition, they propose that the more the data that we include in, the more personalized guidance and therapeutic possibilities we shall derive. This is on the opposite side to the extracting of data and the generalized practice guideline for the specific condition in the acute care models. There are 6 principles and essentials foundation to consider as the prerequisite if we want to use this approach. I shall run through this detail briefly. 2 principles here are meant to ensure that we span our attention to the whole person or the whole organ, not just a cross-sectional presentation of illness symptom or diagnosis. When we look at a person, we need to look through the whole continuum of health, from the fullest feeling of life or wellness, feeling slightly unwell, mild clinical symptom, down to the presentation of specific illness. All are need to be counted. When we look at an organ, we must look at the full function of organ, not just at the size of illness. For example, when we look at the simple metabolic investigation, such as the liver function test and the complete blood count, we need to see beyond the diagnosis of hepatitis, anemia, or acute infection. The complete blood count can give us the pictures of various bone marrow activities, the nutrients that support the red blood cell, white blood cell, and platelet production, the assessment of size and hemoglobin concentration in red blood cells, or represented by MCV and MCH, tell us the status of common nutrients such as iron, folate, and B12. The size of platelets or mean platelet volume also give us some clues of recent platelet consumption from injury, trauma, or inflammation. The prolonged reduction of the total number of white blood cell and red blood cell may hint some evidence such as accumulating toxic exposure, autoimmune process, nutritional insufficiency, or chronic illness processes. Prolonged elevation of lymphocytes may also indicate ongoing immunologic activation. In the liver function test, apart from the transaminase enzyme levels that indicate the hepatocyte's injury, the total protein also represents the total circulating amino acid pool. With additional testing of some short half-life proteins, such as the transthyretin or the prealbumin, this can already help us to detect the amino acid insufficiency or protein malnutrition in most cases. Alkaline phosphatase level is also a good indication of zinc and magnesium status. The persisting levels of gamma GT at high normal range also represent the ongoing environmental toxic exposure in many studies. Without any sophisticated testing, this simple routine lab also already tell us an amount of information with the right approach. The next two other principles that we need to keep in mind when we applying the inclusive data models is to focus on the whole patient, not just one disease entitled, as we always keep in mind that each person is different from other, or the biochemical individualities, which is determined by non-modifiable factors such as genetic predisposition or other modifiable factors such as diet, nutritional status, or environmental exposure. Here is my recent case report in the Journal of Molecular Neuroscience. I report a Thai family that possesses the uncommon genetic predisposition to iron overload, which is the compound variants of transferrin receptor 2, transferrin hemochromatosis, and HGV genes. The father comes with a diagnosis as progressive motor neuron disorder, or ALS, amyotrophic lateral sclerosis, and hypochromic microcytic anemia of chronic disease. We cannot do much for the father, mostly the symptomatics and supportive measures, and he died after 3 years in our care. Interestingly, two sons and daughter have the minor symptom of low levels, low stamina, despite serious laboratory checkup and no diagnosis for other illness except my hypochromic microcytic anemia. We managed to get the data of their genetic variants, the serum proteome, and series of follow-up blood tests in the next 5 years. After some analysis of this data, we found that the family carried unusual compounds of genetic variants of transferrin receptor, thus block the iron uptake into erythropoiesis of bone marrow, which leads to hypochromic microcytic anemia. However, the defective transferrin receptor impacts the signaling pathway toward the hepcidin response that prevent the excess of intracellular iron. When the uptake of iron via the transferrin independent pathway is accumulating, the excess iron causes the damage to the susceptible tissue, which are the motor neurons in case of the father, who never aware of this issue until the advanced stage. Even we cannot do much for the father, we regularly check the iron profiles of the family members and suggest the bloodletting procedure to manage the levels of excess iron and prevent it to go beyond their tolerance. With a history of neurodegenerative disease in family and a chronic anemia condition, we advise them to follow the low carbohydrate diet lifestyle and adopt the time-restricted eating lifestyle to maintain the metabolic flexibilities and reserve their brain bioenergetics. We advise them to do regular physical exercise, but avoid a high-intensity one, as we see that the middle brother one was collapsed after a vigorous training with flu-like symptoms and highly elevation of CPK levels for almost 3 months. That also happened with the youngest daughter that have elevation of CPK for 3 months after she has to go to an elective surgery. As you can see that we did not treat much of the motor neuron disease here. We will never reach our management and lifestyle recommendation for this family if we focus only on the ALS. These recommendations are wholly different from the general guideline with regard to their individual background. This report serves as an example for the true principle of our data analytic models. Accumulating report connect the information and oxidative stress as the central determinants of chronic disease. When we take time thinking about these findings, what did we know about inflammation and oxidative stress? When the external stimuli interact with the living body, human is equipped with sophisticated immune system to detect and defend our body for any harmful stimuli, which can either be the microbe, the foreign particle from incomplete digested food, the toxin, the damaged tissue particle, and eventually accommodate the repairing process. The balance of defending and repairing response tightly intertwined to the process of inflammation and reductive oxidative homeodynamic. Loss of this balance, representing with inflammation and oxidative stress, lead to the development of chronic diseases. These critical defensive response are always the first place to explore when we assess the chronic illness data. The last principle to explore is how our body is interconnected to each other. As an important boundary between external and internal world, the integrity of our gut lining is critical to maintain health. The mucosal-associated lymphoid tissue that lie underneath the guts act as the samplers, the negotiators, the soldiers, and the carpenters. The breakdown of this barrier can potentially lead to the problems elsewhere. There are numerous studies coming out and discussing the gut-brain, the gut-heart, the gut-joint, and other connections through many proposed mechanisms which are beyond the scope of what we are talking today. Microbiome is also buzzing now. The diverse gut microbiome interact with hosts and determine their health, wellness, and illness. What are the key determinants for gut's microbiome? Guess what? Food is a major influencing factor for gut microbiome. While some researchers are obsessing with good bugs and bad bugs, most interests are focusing more on the diversification of microbiotas. We need to have a diverse microbes. Our body will determine how to interact with them and maintain the healthy balance. With good diversification, we know how to properly react to the diverse stranger. When we lost our diversification, we tend to react strongly to someone we never see. This article shows how the change in dietary pattern modify the composition of gut microbiotas and change the biomarker of Alzheimer's disease in cerebrospinal fluid of subjects with mild cognitive impairment. I shall end this principle here with the emphasis on our body response to either the physiological or emotional stressor. Human has a sympathetic adrenal medulla or SAM axis that moderates the response to acute stressor to the convey of signal from our brain to the production of adrenaline in adrenal medulla. For the chronic stressor, the hypothalamus and pituitary send their signal to the thyroid and adrenal cortex to produce the key stressor hormone, the cortisol, to help us deal with this stress. What are the major roles of adrenaline, cortisol, and thyroid hormone? All regulate the bioenergetics. Our body ensures that all needed cells will be supplied with the metabolic fuels when they need it. The stress response always requires the activity of the brain cells, immune cells, and muscle cells. These are all the energy-demanding cells. What will happen if we must continuously produce the stress response for many years? The adrenal cortex will divert all nutrients to maintain the cortisol production. With the prolonged situation, this cortisol steal phenomenon will affect the balance of the production of sex hormone and aldosterone, which are also produced from the adrenal cortex. We often see patients on hormone treatment for their hormonal issues. The treatment is good to manage the symptoms, but it will not lead to their full recovery if we are not searching for the cause of this hormone imbalance. It is quite common that these patients have some underlying trigger that chronically provoke their stress response. If we keep looking, we shall see. The stress response is also the good candidate to show the web-like interaction in human biologies. We have already discussed all principles to set up our analysis model. As you may feel, these contents are not mentioned much in our medical school. However, the medical practice in the 21st century essentially requires this background knowledge. We can collectively name this topic as the nutritional and environmental medicine. While nutrition and environment are important to health, we know that our genes do not always determine our destiny. The genetic expression requires the interaction with nutrient, lifestyle, and environmental exposure to create an individual phenotype, or the epigenetic regulation in more scientific terms. Up to now, we cannot change our gene, but we can do a lot to modify the epigenetic regulation of gene expression to achieve the desired outcome. Therefore, the topic of nutritional and environmental medicine is crucial in this day. What aspect of nutrition that medical practitioners should be aware of? We need to familiarize ourselves with the common dietary journals, such as the diet record, and food frequency questionnaire. These are common methods that used in published research, so we can understand their difference, their weakness, the strength of each method. We can also use it to quickly assess the dietary pattern in our patients in the clinical setting. I routinely use diet recall when I probably need the information during my consultation. I always ask my patient to provide a 3-day dietary record, if possible, when we have appointment. The nutritional assessment can be done through the ABCD acronym, which are the anthropometry, biomarker, and the lab's clinical indicators, and dietary and lifestyle assessment. The body composition assessment through the bioimpedance analysis, or BIA, is also helpful. Some model machines provide a visual fat rating scale, which can be highly informative. When we see someone with healthy lifestyle and not excessive with the alcoholic consumption, but presenting with a remarkably high visual fat rating, this finding indicates the accumulating anabolic promotion from some underlying metabolic dysfunction. Apart from this, different dietary pattern, the food-gut microbiome connection are all the topics that we need to appreciate. There are numerous dietary patterns with different macro and micronutrient composition out there. No single diet will fit everybody. It is more depending on individual underlying condition, preference, and belief. We need to use all information to come up with a personalized pattern that may work best with these individuals. We then need to understand the difference of this dietary pattern and have them available on hand to use when needed. The concept of metabolic temper that I propose in my publication is also important. Eating pattern is important, but eating and fasting timing in the day is also influencing the outcome. The human study also show that when we ask people to limit their eating period in the day, they spontaneously reduce their intake. In my practice, I often ask people to work with their eating periods and focus more on what they eat, more on nutrient-dense and food rather than the caloric-dense food. I rarely ask people to limit their eating portion because, it's against their will. The next point is the shifting of nutritional science in these centuries. Decades of nutritional science developments make us appreciate the disease that develop from the depletion of one nutrient and the replacement of that nutrient restored to health. Food is mainly representing the source of nutrients and calories, but food has many roles in health apart from that. Food can act as a signal information and influence our gene expression to the microbiome and gut-associated immune interaction. Food can signal the connection between the different biological systems. Food is also our best medicine. Let's look at the vitamin D. We know that vitamin D deficiency leads to osteomyelitis and rickets. The IOM set up the cutoff levels of vitamin D at 20 nanograms per milliliter, while the Endocrine Society made it slightly higher at 30 nanograms per milliliter. But these cutoff levels are based on the function of vitamin D that moderate the calcium absorption. Upcoming research suggests the role of vitamin D in many aspects of health and disease, including the gut barrier function, the metabolic disorder, the cardiovascular disease, the autoimmune disorder, cognitive dysfunction, and cancer. What is the target optimum levels of vitamin D based on these outcomes? The current cutoff levels of vitamin D is obviously too low. However, the survey of the Korean National Survey in 2008 to 2009 confirmed that the prevalence of vitamin D deficiency in children is really high, even when we use the cutoff as 20 nanograms per milliliter. Nutrient deficiency or insufficiency is then a critical determinant for chronic illnesses. This is another one of my publications on COVID-19. We explore the roles of micronutrients and their role as the immunomodulator against SARS-CoV-2 infection. When we look at the roles of micronutrients to the immunologic response to virus infection, from innate immunities, adaptive immunities, and counter-regulatory immune response, there is no role for a single nutrient. All healthy response require the support from multiple nutrients, while the deficiency of most nutrients increase the individual susceptibilities to virus infection, with a tendency toward the more severe clinical presentation. The supplementations of single nutrient is not very promising in the general population. So what is the solution? We propose that an individual dietary and nutritional status assessment are critical. You can see how the nutritional medicine works as a foundation of our modern day clinical practice. Let's look at the environmental toxic exposure. The shifting trend is similar to these in nutritional science. The modern day toxicologists need to consider the chronic and low exposure doses of toxin and their contribution to chronic illnesses. The cutoff levels and the assessment method are also need to change to accommodate this drifting trend from the classical dose-response relationship in classical toxicologies. I give an example of lead exposure. High exposure to lead lead to death. The cutoff level of lead in whole blood gradually come down from 50, 30, 10 to the current 5 microgram per deciliter levels. But even at the levels below 5 microgram per deciliter, a lot of studies still suggest the possible neurodevelopmental impacts in young children. It is actually looking at no safe levels of lead in human tissue. So it is depending on the susceptible host. In my publication on arsenic and neurodevelopmental disorder, we discussed the possibilities of combined exposure of multiple toxins, the role of genetics, and the nutritional status. One of my publications on hair minerals level showed that the presence of one mineral always associated with the increase or decrease of one or many minerals. Like the essential micronutrient, the health impacts of environmental toxins are likely to be the combinations of multiple toxins. We then need to re-evaluate our toxicological approach and move away from the acute toxic exposure toward the modern day toxicology that need to concern more about low exposure and chronic ongoing exposure. What about the prevalence of combined toxic exposure, nutrient deficiency, or excess, and health impact? The study of 110 well-nourished students in Bangkok and perimeters showed a high prevalence of combined aluminum, arsenic, cadmium, and lead exposure. The increased level of zinc in their hair is also significantly associated with the hyperactivity and inattentive symptoms in these children. The high excretion levels of zinc into hair may suggest some individual difficulties of zinc handling, which contribute to the ADHD symptoms. There is another article under the review process that report the extremely high iodine status in Thai children. This brings to the concern of the over-fortification of iodine from the government policies and the consequences of iodine excess to health. That will conclude all the required principles and the foundation to set up our analytic model for the functional medicine approach in clinical setting with the aiming output toward the personal lifestyle modification recommendation for an individual with chronic illnesses. Next, we shall discuss about the functional medicine approach. Among many approaches out there, from integrative medicine, evidence-based medicine, chronic care model, personalized medicine, what is the positioning of the functional medicine model? I visualize functional medicine as the method and tools to reach the output of personal lifestyle or P4 medicine. Other disciplines of medicine differ from the functional medicine by their models and their targeted output. Let's dig into the process of FM big data handling. What should we do when we are dealing with tons of data? The common approach is to try to recognize the pattern in this data. What pattern that we are expecting for? In FM approach, we try to organize the patient data into a storyline, which comprises an antecedent, or the underlying conditions, the triggering events, or something that activates the clinical symptoms, and the mediators, or something that keep the patient in the vicious loop and preventing them from that recovery. With this pattern recognition, it will help supporting the development of personal lifestyle recommendation. When we gather the data, we need to put it into order to make it easier to visualize. The clinical data are mostly the temporal data or the data with timestamp, which means that this data event always happen at a specific time. The FM proposed the timeline as the data visualized tool for clinical practice. Here is an example of functional medicine timeline. There are more details in this timeline, which I will discuss later. But as you can see, if we put the clinical events in timeline series, it would be easier to start to see the time sequence and the connection between each event. The FM timeline is dated back to early life events. The history of infancy colics, the severe illnesses, antibiotic exposure in early life, particularly first 2 years of life, are extremely critical for adult health and illnesses. The emerging study also support the role of immune system development and the disrupting microbiome and other factors that may influence long-term health. The final goal of data clustering is to get the group with the highest similarities within the cluster while keeping the least similarity between clusters. There are many algorithms to cluster the temporal data. This is how we cluster the data in conventional medical approach. We group the data into the organ-based cluster, such as neurologists, cardiologists, immunologists, or else. If this is a picture of a big tree, this cluster could represent the group of leaves and branches of a big tree. If our focus from organs to the whole tree as required in the principle of our analytic model, we see that the leaves and branches always require the support from the trunk and root of the tree. If we cluster the clinical data with the focus on trunk and root of human health, FM clustering algorithm suggests the grouping the critical data of host factor into the modifiable and non-modifiable cluster. The non-modifiable cluster serves as the tree root. These include the genetic predisposition, the experience, the trauma, the belief, the mental, emotional, spiritual influence of the individual attitude. The modifiable cluster serves as the tree trunks that supply nutrients to leaves and branches. This cluster comprises a subgroup of underlying human physiologies that are the cluster of defense and repair, bioenergetics, assimilation, biotransformation, elimination, transport, communication, and structural intricacies. This cluster spans through the host web-like interaction of human physiologies that are differently clustered when comparing to conventional organ-based systems. The purpose of this different clustering system are to integrate the function of one or more organs that work together, which could allow us to liberate ourselves from the constraint of organ-based thinking. An example that I have mentioned earlier is the integration of immune response and reductive oxidative hemostasis into one cluster of defense and repair group. In the context of conventional medical education, these two functions are mostly separately discussed. The next FM cluster is the clustering of lifestyle factors, including dietary pattern, nutritional status, hydration, exercise, movement, sleep and relaxation, stress and resilience, relationship and network, and the environmental and occupational toxic exposure. The clustering concept here is to see the pattern of different groups of the internal and external factors and try to see the dynamic interaction between this cluster. As we try to make sense of this cluster, we shall see that human health or illnesses could stem from various triggers, such as toxin, antigens, microbes, stress, and bad food. These triggers interact with internal hosts and influence the individual patterns of gene expression, which set up the underlying pathophysiologies and all the antecedents that accumulate the route toward illness. This can be assessed by various biomarkers, including the modern omic technologies. The next level of illness, subclinical pathology, is expressed as the imbalance in host biology, which are clustering as the host factors. This usually can be assessed by the clinical laboratory testing. Most standard clinical testing already provide clues for this imbalance if clinicians are looking for it. The sophisticated, expensive, and advanced functional tests that are commercially available now are needed only in few cases that need more data for confirmation of some issues. The barrier of functional medicine approach is the change of principle from conventional way of thinking and use this FM principle while we assess this clinical data. You will see it if you look at the data in the right way, at the right place, and look at it hard and long enough. This is the summarization of FM concept, or what we call the functional medicine tree. You can see the connection from the root, the trunk, up to the branches and the leaves are all the organ-based system of this big tree. While the tannings of leaf and branch that turn yellow or dry with scissor is necessary, the care of trunk and root that supply the nutrients, protects and maintain the communication and interaction of internal and external world are also crucial. This is a tool. This is a tool called functional medicine matrix. You can see the cluster of host factors in the middle, the cluster of lifestyle factor at the bottom, the ATM or antecedents, triggers, and mediator at the left column is a summarization of derived pattern. We shall use this derived pattern to retell the patient story back to them to ensure whether all information collected is correct. This pattern also set up an initial working hypothesis and guide any confirmation testing that may need in next step. However, this is still pretty confusing. How can we apply it in the real clinical setting? This is the example of my initial consultation worksheet that I used during my consultation in clinic. I put the timeline on top of the sheet, the matrix in the middle, and the ATM mappings on the left columns. Of course, I request all my clients to provide information through a list of medical history questionnaires, and I take time to cluster their data into this worksheet to get some idea prior to my consultation. During my session, I put down the findings in the space of corresponding cluster. I'm still preferring the write down with my handwriting. I know that there are some software coming out to help us better organize the information. However, as an old guy, I still work on it in the traditional way. After data clustering, the next step is to try to see the pattern of these clusters. What we want is the underlying pattern that leads to the clinical situation. In this article, the author discussed the various causes of chronic disease and proposed to include all the potential causes into the consideration, which are the risk factor, the proximal cause, the medial cause, and the distal cause. This is one way to put all these distributing causes into a pattern. However, functional medicine approach proposes a different way of getting the underlying pattern. As I have mentioned earlier, FM will organize all data and rearrange into the pattern of ATM, of antecedents, triggers, and mediator. This antecedent includes the family history or the genetic predisposition, history of trauma, toxic exposure, intrauterine history, sexual abuse, intestinal permeabilities, infections, dietary insufficiency backgrounds, or the history of recreational drug usage. The triggers are things that trip the patient down the road of illnesses, which could be the intense physical or psychic trauma, microbe, toxins, stressful events, extensive surgery, or severe infection. When we get sick, the healthy people should readily bounce back after a certain while. However, a chronic illness individual is stuck into the vicious loop and slow or unable to recover by themselves. The mediators are things that keep them in this illness loop and current clinical symptoms. This could be the inflammatory cytokines, the ongoing psychological stress, ongoing exposure to environmental insults such as mold or chronic sleep deprivation. When we organize all clusters into this ATM pattern, we shall tell it back to the patient to ensure that all the information is accurate. As I previously mentioned, this pattern will serve as the initial working hypothesis and set up the next action plan for the laboratory confirmation or the individual recommendation. Have collected data, cluster them, derive an initial pattern. Next step is to get the additional data to confirm this hypothesis and move into the concluded pattern. At this stage, I shall skip the various laboratory testing from this presentation as it has more details and are ways beyond the scope of my today's talk. When we see the underlying pattern that lead to the patient to the chronic health or illnesses, what recommend we should give to the client? In the derived pattern, we shall look at all the modifiable factors that can leverage the underlying pathophysiologies. These include the dietary pattern, the nutrient insufficiency, the lifestyle modification, exercise, or stress management. These recommendations are coming as a lifestyle modification protocol, not a single advice. The clinical working process may follow the classical Deming cycle of plan, do, check, act. However, we may adapt it into find, assess, execute, and monitor. We assess the data, we cluster, we derive the pattern, we confirm the pattern, suggest an intervention, monitoring the response, and adjust the protocol to fit more to that specific individuals. I may need to emphasize here again of the desired output of functional medicine approach. It is the P4 medicine or personalized lifestyle modification, not the vitamin supplementation, the hormone replacement, the detoxification program, or the expensive functional laboratory testing, or any complementary treatment. Of course, this option can be considered as a part of the lifestyle intervention as the immediate short-term support. But the long and sustainable goal of this approach is a lifestyle modification that fits to an individual background. You may notice that these personal modifiable lifestyle factors are listed at the bottom of functional medicine matrix. Next session, I shall discuss a few case history to demonstrate the implementation of functional medicine concept in clinical setting. The first case is a Thai woman, 43 years old. I first met her in 2011 with the presentation of proteinuria. She was under the steroid treatment for almost half a year and come to discuss other treatment options. After the assessment and laboratory testing, here is the pattern that I saw. She has a compromised gut barrier, which shows as a multiple positive IgG antibody in the food sensitivity panels. The major dilemma here is that she was told to keep taking egg every day because she lost the albumin into her urine. With the compromised gut barrier, the undigested egg peptide react to her gut's associated immune system and sustain the inflammatory reaction despite no noticeable symptom when she exposed to the egg. The high retention of mercury and acid in her red blood cell and the low ratio of reduced to oxidized glutathione indicate the high toxic load and the ongoing oxidative stress. This will further compromise the young epithelial lining cells of gut barrier. I recommend her to avoid eggs and other reactive food, control the exposure to arsenic, which are mostly the rice-based products, and the mercury source, which is mainly from the fish and seafood products. She needs to regularly consume the colorful vegetables that provide antioxidant, anti-inflammatory phytonutrients, and keep variation on her dietary food menus to avoid the additional exposure to other environmental toxins. She also needs to ensure adequate hydration, avoid constipation, and maintain regular exercise. I worked with her for almost 6 months and never saw her again. She came to see me again this year. After all 10 years, she told me that the proteinuria was completely gone. She's completely discontinued all medication, but she still maintained a healthy lifestyle since then. The reason she came to see me this time because she noticed that her neck is enlarging in the last 3 months and her doctor started to put her on the steroid and plan to do the biopsy and probably the surgery if the mass is still big. Again, after the reviewing the data and some confirmation tests, here is the pattern that I see. Her enlarged thyroid is not the result of autoimmune process, and the thyroid antibody is not that high. It is probably the result of inflammation as the ESR and CRP are elevated. And what caused the inflammation? Food triggers are the potential activators. As the IgG antibody to food is elevated again. The oxidative damage is also confirming as the membrane oxidation representing by MDA or malondialdehyde is elevated. And the red blood cell retention of cesium and mercury are beyond the 2 standard deviation percentile ranking. The toxic retention and oxidative damage again contribute to the compromised gut lining, prone her to react to common food protein and induce inflammation, which is attacking the thyroid, causes swelling in this tab. She manipulates her diet by elimination, and the swelling in her neck subsides in just 2 weeks. Why this pattern is repeating after 10 years? So my best guess is she is likely to be an individual with genetic predisposition to the poor handling of these toxic metals. When she repeatedly exposed to this contamination, it's induced the oxidative damage and create the underlying pathophysiology that allow the food trigger to kick in and induce the clinical symptom. The next case example is a 7-year-old boy with severe dermatitis and progressively decreased his tolerance to food over time. He was treated with inhalers, antihistamine, with frequent course of antibiotics. His BMI 4H percentile rank is at 30 seconds, which is a little bit on the low side. Assessing all data and findings, we saw that the multiple positive of IgE testing for food and inhalation antigens. The IgG pattern also shows multiple severe, moderate, and mild reaction to food. He has high inflammation as seen in high CRP and ESR. He also has vitamin D deficiency, which is not supporting when you have immunologic dysfunction and compromised gut barrier. The good side is that we didn't see the elevation of thyroid antibody, which means that the pathological process is unlikely to go further down to the autoimmune route. The pattern we see is an individual with hyperactive adaptive immune response in both IgE and IgG reaction. And of course, the vitamin D deficiency is not supporting the situation at all. We suggest the whole dietary elimination modification, few nutritional support, mainly the probiotics and vitamin D. 3 years later, in this follow-up, his BMI 4H percentile rank come up to 69, indicating the improved nutritional status. His dermatitis is improving, no observed scratch mark. His skin is quite healthy. He still has occasional attack of asthma, but he does not need daily medication for now. The purpose of the visit is to get the idea of food reintroduction as a follow-up, as the follow-up IgE testing with a conventional doctor during the past 3 years show few numbers of positive items. And this is the comparisons of IgG testing 3 years apart. No severe reaction coming up, one moderate reaction, and few of my IgG response. The gut barrier function is definitely improving, but it's not completely normal yet. He can initiate the reintroduction of reactive food one at a time on a rotation basis, but he needs to maintain the eating pattern that promotes his gut environment diversification. Let's quickly go through a case of Bangladesh boy, almost 6-year-old with a neurodevelopmental delay in the area of speech, social communication, and repetitive behavior. His dietary pattern is balanced, but he's eating fish almost every day. We went through the data and tried to derive the possible underlying pattern. He has high whole blood mercury and lead with marginal nutritional status. What we saw is the ongoing exposure to multiple environmental toxins, which probably come from his habitual hand-mouth behavior and his dietary pattern and his borderline amino acid and micronutrient insufficiency. This lead to the compromised gut barrier and ongoing reaction to food again. The last case presentation is a woman with recently diagnosis of rheumatoid arthritis. She frequently consumed fish and seafood. After the data processing, that led us to conclude the pattern of autoimmune response with slightly compromised gut barrier from high retention of toxin and oxidative damage again. I shall skip the lifestyle recommendation, but this example should be adequate to show the approach of functional medicine with the background of nutritional and environmental medicines in clinical settings. Next, we shall discuss how it looks like when we do the functional medicine in clinical practice. As you see here, in the practice of functional medicine, we, the doctors, are not the one that provide the cure. Doctor is just an advisor, helper, but not the healer. The patient and the family members are the main driving force toward their recovery path. We, doctors, as such, can suggest, monitor, ensure whether their actions are on the right track. Most of the time, the initial recommendation will be adapted to fit an individual lifestyle, preference, belief, and else. In FM practice, we then need a team of nurse, nutritionists, dietitian, complementary and alternative practitioner, and physical rehabilitation staff. In fact, we need a team that called health coach that can build a therapeutic relationship with the patient and family members. The team needs to understand and equip with the background of nutritional and environmental medicine. They need to use the right approach to help people at the different stage of behavioral change ladders. When people lack awareness, we should work with providing the right attitude or finding their motivation. When they are ready to move on, but lacking of knowledge, we can start to talk about the concept of lifestyle modification. But when they are ready to act, we can provide the tools and other support. We cannot use one approach in every patient that's coming into our clinic. The practical side of FM in clinic. We can target people with unwell symptoms and want to achieve the next levels of wellness. This is where most of the anti-aging people are working on. We can create the in-house workshops such as 3 days, 7 days, or 14 days that allow people to come in, get assessing, and experience the results after they start the intervention. We can do a group talk, a group sharing, or food workshop to allow people to come in, share their experience, and ask questions or else. A lot more to explore and move further in different areas of chronic illnesses. The point of these presentations are to emphasize the importance of paradigm shift of knowledge and provide some idea on the functional medicine approach. While the real-life practice always requires the supporting team, the researchers, the publication, and the international collaboration will help people to appreciate this approach more in the future. And that should end my today's presentation and open for any question that may come up.
Thank you very much, Doc. That was very thorough. And I agree that the doctors is only the advisor, is only the life coach. If you agree with that, and the patient is actually their own healer. And that therapeutic relationship that sometimes that they reach us in any time convenience to them, that because they need help. You experience that too, right? And also I wanted to take note that for everyone here to note also that supplementation on single nutrients are most of the time are not useful. So that means that multivitamins, you have to make sure that you are sufficient in multivitamins first before you can actually add more or additional depending on what you need.
Yeah.
after our assessment.
Actually, there are tiers of supplementation. You know, if you don't have any information, you may start with something like a multivitamin, thing like that. You know,
Yep.
but single nutrient supplementation, you need some information to confirm before you go to that route.
Yep. Yep. Okay. So because sometimes I know that they only take B vitamins alone or vitamin E alone. So without knowing that they actually need the foundation, the multivitamin first before they actually can add what it is they actually need. That too. And also the heavy metal, like what you said, there is actually no safe level. So we never can see the normal range given by the lab, because whatever it is on that range is actually we don't want it. That's what you mean, right, Doc?
Yeah,
so
that is right. And it's also depend on the assessment method as well. You know, most of the assessment method now, they use the whole blood analysis, which is the acute toxic exposure assessment, not a chronic. Right?
Yeah, because you actually make new blood every 3 months, something. So depending on when you actually take the sample, that's not the accurate reading for your heavy metal level. That's what you mean?
Actually, you know, in toxicology, we use a whole blood to represent just a few days of exposures. The whole blood levels, it's a combination of the level in the serum mainly, and together with fields in the red cells, in the tissues. So normally the levels in the whole blood is represent only very recent exposure. But in chronic health, you know, we want to see something that deposit in the tissue, not circulating in the blood. So we need to consider other type of assessment, something like the packed cell analysis, right? Check the levels in red cell, which is at least one life cycle of red cell, 4 months, thing like that.
All right. Okay, so what do you use, Doc? You use that challenge test that people talk about, that you have to do the urine?
Not really. So normally I'm going to start with a red blood cell analysis if I want to really check it, all right? But in Thailand, we can do the membrane damage, oxidative damage test, something like an MDA, right? So I'm going to screen with that thing first. If it come up positive, okay, sometimes I go for a more advanced test.
Yeah. Okay. All right. Also, that is the some patients sometimes said that the functional medicine it's expensive in testing because they test a lot of stuff. But I agree with you. Actually, the routine blood test, the CBC and all, is actually can already show us a lot. So then we can actually not need to test a lot of things. Just depends on what your CBC tells you. Right. Yeah.
Actually, in my practice, I use most a simple metabolic test to screen first. You know, I may add something. MDA, it's available in Thailand, but it's still quite expensive, all right? But in some case, when I review the history, I might include it. But in general, you know, the simple metabolic test tell us something on the nutritional status or the inflammation or the immune activations already.
Yeah, I got that patient, Doc, with that rare, just recently, the rare iron metabolism. So the doctor just didn't know why this patient always have high iron but low hemoglobin and osteopenic when he was actually not so old. And then I found out that he was actually the carrier for alpha thalassemia with the low hepcidin in the study. So that it just felt good that I can finally give him an answer why after the whole testing.
But be careful. Sometimes there might be more than one cause, right?
Doc.
In my case report, you know, I have to take almost 2 years, you know, to try that kind of uncommon variants in his whole genome. You know, I get a set of gene variants on a whole family, and I look at the common, what they call a hemochromatosis gene variants,
Yeah.
but I didn't see it. It's all normal, right? And it took me almost 2 years to
Yeah,
go through
yeah,
all
yeah.
these things, but it's fun.
Yeah, I think I heard you sharing this story in Singapore sometimes with Slim meeting. So
Right,
anyway,
right.
Doc, I'm sure there's a lot of question for you. Dr. Lisa, is there any question? Lisa?
2 questions already.
Yeah.
We already have 2 questions. The first one is, doing functional medicine already mapping the use of micronutrient in several enzyme activity in cell, like zinc, magnesium, selenium?
Thanks for the questions, right? Normally, I reserve it if I want to confirm whether that particular individual have some, what you call, unusual patterns of utilized nutrients or not. Something like zinc or magnesium. Normally, I'm gonna try to look for the clue in something like the alkali phosphatase level in the liver panels. You know that nutritionally low alkali phosphatase levels can represent the low zinc or magnesium, because zinc or magnesium is a key, what you call, cofactor of this enzyme. And yeah, again, zinc is pretty common if people come with a chronic gut issues, because our body didn't store zinc that much, right? Most of the zinc that stay in the epithelium gut lining is gonna be excreted, lost if you have chronic gut inflammations. That is another clue, yeah? So we get the information from the history, from a few lab tests first. And if we need confirmation, sometimes I do the red cell analysis of this mineral.
Doc.
Yep.
Second question. Second question is, what do you use for mercury poisoning and how many dose and until how long as per your experience?
How many? What's how many?
Okay.
What do you use
chelation,
for?
right?
Yeah, I think it is, Doc. Yeah.
It's not about only chelation, I think. The question is, what do you use for mercury poisoning? I mean,
All right.
probably in nutritional. Yeah.
Okay. So as a toxicologist, right, the first rule to handle the toxicity is the exposure control.
Yeah.
That's the reason why when I see people with oxidative damage, I want to know what is the individual toxin that caused that things, right? Firstly, I'm going to start with control the exposures. If it's mercury, mostly we see that it's contaminated most in the water sources, right? So we have to ask whether they eat fish or seafood quite often or not. If it's arsenic, sometimes we have to look at the rice-based source, right? The rice in Asia is pretty much contaminated with the arsenic, thing like that. So we have to ask them to control the exposure source first. And secondly, we have to make sure that they have a good foundation of macro and micronutrient adequate to handle those toxins or not. That is my second step. If they have nutritional deficiency, I'm gonna try to do everything to improve their nutritional status first, right? And the third one is I'm gonna ask them to encourage the excretion. Mostly it's coming from the hydration, constipation, right? Exercise, thing like that. I rarely use any kind of like chelators or things that gonna directly try to excrete that. I normally work with the foundation first. Okay, there might be something like if it's late, sometimes I'm gonna recommend the calcium supplementation just to compete with the late absorptions, and if everything is quite good and I see the tissue level deposition, it's sustained quite long, I'm gonna start a low dose chelation with something that we know it's quite safe, something like a DMSA oral thing at a low dose as an intermittent dose, thing like that. but I always use it as the last option. But that's a little bit different from some other protocol, but this is my approach.
Yeah.
Okay. Thank you, Doc. Next, can I drop you next questions? Because I
Yes,
think the
yes,
questions
please.
keep coming in. Okay. Next questions is, as the physician who wants to see the nutritional map of micronutrient and considering the financial capabilities of Indonesian people, what is the best thing to check instead of checking the whole test? What would you be recommending? Thank you.
Okay, that's a good question, right? So we have to look at firstly the macronutrient first, right? We want to see whether they have a macronutrient insufficiency or not. You know, the most important macronutrient insufficiency is amino acid insufficiency. You can look at the total protein in liver panels, which is represent the circulating total amino acid pool, but that is not enough, right? You have to combine it with what I mentioned in my presentation is a short half-life protein. It's a prealbumin, right? Or the new name is transtitylin. These proteins stay only a short while in the blood. And combining the total protein and the prealbumin levels, you know, you can mostly detect the borderline amino acid insufficiency in most of the case. That is a macronutrient. And like I say, CBC and liver functions already give you some clue about a micronutrient like a zinc, magnesium, folate, ions in that's already. So for the budget wise, you know, if you give me a metabolic panel like a CBC and liver function test and kidney function test, that's already give me some clue about nutritional status. Is that answer your question?
Is it Dr. Ade?
This is Dr. Ade Mutiara. Dr. Ade, you can unmute.
Yes, thank you, Doc. It's already answered. I'm quite happy with your explanation. Appreciate it. Thank you.
Okay. Next one, Liz.
Thank you, Doc. Yes. Next one will be, how long would you suggest an elimination diet in a case like a 7-year-old boy with severe dermatitis and asthma? Also, will you allow a reintroductions on any group of allergens like gluten, dairy, nuts, seafood, or will you limit all of that?
Okay, that is another good question. So it much more depend on each individuals, right? For that boy, that we see that he have a tendency of hyperactive immune response. I'm gonna be a little bit more careful. You know, we have to understand that why our body have to produce the IgG antibodies, right? Of course, you know, that is one part of immune response, but your body produce this kind of long-lived antibody because they have first bad experience with that antigen before. And once when you have the bad experience with something, your body gonna send the signal to what we call long-lived plasma cells, you know, something that gonna stay and keep respond to only just even a few amounts of trace of antigen that coming in. So you have to make sure that that individual gut barrier function it's recover at certain point before start the reintroduction. I see some people that do a lot of good things, right? But they are slowly to recover. But I also see some people that they do it 2 weeks, 3 weeks, and they get a good result. You know, so I don't have any specific time period for elimination. Normally, when I start to give my recommendation, I ask them to try it for at least 3 months, and I'm gonna reassess them again and tailor my recommendation depend on how they respond.
3 months, Doc?
Yeah. At least 3 months before you can reassess the response of that, right?
Okay, thank you, Doc. To Dr. Vidya, is this answer your questions, Doc? You may unmute if you would.
Thank you very much. Thank you very much for your answer. I have another question. So when you assess, are you asking your patient to redo all the lab tests or just certain markers like CRP and certain IgG before you can recommend further advices?
Okay.
Or just based on clinical symptoms?
Yeah, thank you for the question, Dr. Vijay. Actually, when we first do the analysis, right, we're gonna see what is the specific point that we want to monitor in that particular case. You know, normally in the follow-up visit, I'm gonna check only things that we want to see. If people come with something like high MDA, high membrane damage, you know, after they do all the recommendations, I want to see that in 3 months, whether the membrane damage level is coming down or not. Yeah, sometimes I just check only a few things. I think that is it answer your question?
Yes, thank you very much, doctor.
You're welcome.
Okay, I have another question, Doc. It's about a patient with 6 months post-COVID-19, which has been, actually, Dr. Anggi has a lab result. Can I show it to you or?
Yes, please.
Okay, Dr. Anggi, you may unmute yourself, Doc, if you would like. Dr. Anggi? Dr. Anggi? Okay, you cannot use voice. Okay, so I will try to ask the questions. The point is, this is a post-COVID-19 patient already 6 months ago, and the now problem is that he or she still feel very, very weak, and there are already a low ACTH, and on the PCR swab, it's already negative. But I think there hasn't been COVID-19 antibody yet. So, okay. And there are also a mercury history. Okay.
Okay.
Yes.
So I from what I heard, right, it looked like the patient have went through a severe infections.
Yep.
And what I see is
inflammation.
All right, he has a low ACTH. That means the major stress response is already down. So in this case, I just want to see the information about his current nutritional status, because when you pass through that severe infections, right, it's gonna demands a lot of nutritional support. You know, so I cannot specifically answer it now, but it would be nice if we can assess his macronutrient and micronutrient status. You know, because if you see that there are some signs of HPA dysfunction like this, right? Most likely, if the infection is not active, most likely the supporting macro and micronutrient is gonna be down. That is my best guess for now.
Yeah. It's also possible that the ACTH is already lower before that COVID, maybe. Yeah, though?
Yeah, we don't know yet, right?
Yeah, because of the mercury.
Maybe that is the condition before he exposed to the COVID-19. We don't know, right? But of course, the COVID-19 is trigger. It strip him down to the loop of this vicious cycle.
Yeah. Yeah.
Yes. I think there are already a problem with the ferritin also. Okay. If you still have got time, I would like to share you, but I need to email this first because it comes from my phone actually. Can you wait though?
Yeah, sure.
Okay, thank you.
Any other questions for Dr. Torsak while he's here?
Yes, for the other doctors, please, if you would like to ask Dr. Torsak.
So, Doc, that you mentioned about the P for medicine and the fourth P is the participatory. Is the patient to participate on that health journey?
Yeah, it's a proactive, right? You know, the success one is gonna be the patient with proactive involvement in the program. So if someone come and looking for a cure or a magic, you know, it's not gonna work with this approach.
Yeah.
So normally with that patients, we need to find them kind of like a change the attitude, right? You know, and don't want to try to work that much, right? Normally we don't advise things that is more complicated. You know, so participation is really the key for success in this practice.
Yes, I agree. There's a few patients here that been with me for a while, and well, I think they like the idea about the approach in this functional medicine. So when I put this in my Instagram, they ask to join. I hope it's not going to burden them with all the theory.
No, you know, but what we want is people like interest in the idea and they want to join. So our role as a doctor is we're not gonna ask things that more complicated or more difficult for them on the first place, right? People come with a body weight, excess body weight. We're not gonna ask them to eat less and exercise more.
Yes.
You know, something like that. Okay, you know, can you eat in just 12-hour a day, thing like that? You know, not eat the whole
Talking
day.
about that, what's your say about that? So many different kind of diet right now, the keto diet, the FODMAPs diet. What you say about that?
You know, it's different purpose, right? I have a client that get quite a good results from ketogenic diet. I have someone that prefer to move on a carnivorous diet because they cannot tolerate the fibers, right? You know, but it's depend on their conditions. You know, it's depend on conditions. So I'm open for all the type of diet, yeah. But it's depend on you know, when I recommend one diet, I'm gonna keep in the reason why I recommend this diet. So that is from my views, and also from their view as well. Yes, their belief, their preference, thing like that. So we have to match all these things.
Yeah, and keep in mind the macronutrient and micronutrient sufficiency.
Definitely. And of course, when people come with the lifestyle of vegetarians, thing like that, what you have to pop up in mind is B12, thing like that.
Oh yeah. Yeah.
So there are specific concern, right, about it's a strength and weakness of some certain eating patterns that we should be aware of.
Yeah. No, they're so difficult to get rid of heavy metal, right? No. So
it's depend on whether you know the source of exposure or not.
mm-hmm.
First thing, right? It's depend on one is they just keep exposed to it on the daily basis.
Yeah.
The most common source is the food. People tend to eat the same pattern of food too often.
Yeah.
Even the colorful vegetables, if they eat it from the same source every day, the same type of vegetables every day, things like that. So they expose themselves to the same contaminant. So more or less, you should keep variation as much as possible.
Okay, but so you already said that if all other efforts to bring it down fail, then you try on the chelators.
Yeah. If we already build up a good foundation in terms of lifestyle and nutritional status.
Yeah.
Doc, can I ask one more?
Yes, please.
Yes. What is your suggestions with taking histamine block as supplement to reduce the inflammations?
It's a medication.
What's your opinion about that? Do you ever suggest any histamine blocker as supplementations or not?
I'm not against the medication. Okay. If people are suffering from the histamine effects, right, they have scratch, rash, things like that. Of course, I'm going to use medication to control the immediate symptoms while we are waiting for all the lifestyle things. And if the symptom is not that bad, sometimes I recommend something like a quercetin. It's a supplement, right? The quercetin from the peels of the apples, thing like that. Quercetin at around 2 grams per day. It can stabilize the mast cell. So it's also have the antihistamine effects by itself.
Yeah.
But again, a supplement is not my first choice. I always encourage people to work with the food. All the colorful leafy vegetables already contain anti-inflammatory, antioxidant, phytonutrients, things like that, if they take it regularly.
Yeah. Supplement is only supplementing the healthier lifestyle, though. Not to,
that's right. That's right.
So you cannot have a horrible lifestyle and then you rely on your supplements. That's just no.
Yeah. I see some people take some supplement before they went out and go parties, things like that. So.
Well, I have a colleague, Doc, that take Crestor everywhere. So she's actually a specialist, an internist, but she took Crestor everywhere. So whenever she ate naughty, then she took the Crestor.
Yeah, that is another big topic about whether cholesterol is a big problem or not. That is a big topic because in some case some patient with high inflammation, but the total cholesterol is not that high at all. So that is concerning for me, right? If you have inflammation, your body want to produce the stress response, but they cannot, produce more of the cholesterol. That is concerning.
Agree.
So, Doc, I already get the question is, do we still have time? Because I already down. Yeah, are you okay with this?
Yes.
Okay, so can I share screen.
All right, please.
All right. I think this is the first one. Can you see it though?
Not yet.
Not yet. Okay.
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 This is the morning cortisol, right?
Dr. Anggi, you want to explain the patients?
Yes,
right.
that is the morning cortisol though. It looks just only one time morning serum cortisol.
Okay. So definitely the DHEAS and the cortisol is too low. Right? The DHEA and the cortisol is too low.
Yep. So in relation to other hormones, doc, look at what is,
you know, when I look at adrenal panels like this, you know, the most important thing is the DHEAS sulfate and the cortisol. You know, so for the sex hormone, it's depend on the cycle as well, right?
yeah.
But if you see the low DHEA is kind of like you know, almost the precursor of most of the adrenal hormone.
Yeah. Yeah.
Yeah, and normally your our body is gonna try to sustain the productions of cortisol, but 5 in the mornings it's not that good at all, right? So
Yeah.
whether he has a chronic illness problems or his sleep is really that bad.
Yeah. Yeah.
So this is, you know, typically the HPA dysfunction, right? The
Yes.
compromised stress response. So like I said before, right? In this case, I want to see the information about macronutrient and micronutrient that support the stress response.
Okay.
Is this the same patient? Is this the same patient with the post-COVID?
No. Here I go with the, I don't know, is this the same?
And yeah.
Is this the same, doc? I mean, this is the same.
This is different, right? And if it's in the morning, the insulin is quite high.
It's a fasting insulin, looks like, no?
Yeah, it's too high.
Yeah.
It's too high. Ferritin, yeah, it's average. Serum ion, but we didn't see the TIBC, total ion binding capacity, so we cannot calculate the transferrin percentage. The total cholesterol is slightly. Yeah, so I would say that the morning insulin is quite high. So he have a certain degrees of insulin what you call glucose intolerance. That's might reflect how the body try to pull out the reserve energies to deal with the current situation. And as we can see that the cholesterol is slightly up, the triglyceride is above 100. So the patient is still exposed to carb quite at a certain amount. I know. Yeah, but in this case, if you want me to look through the details, you can send me the the case history and the labs, and I can help to make sense of that, right? But normally we also need the information from the patient as well.
Okay, no, okay. I will try to send, probably I will ask Dr. Angie to share the patient's data more.
Yeah.
And maybe there are already another questions. So I'm gonna stop sharing now and let's take a look at the chat room. Thank you, Doc.
I think there's I think that is all, right? Nothing else?
One, just share my thinking about the post-COVID case, right? If the symptom is quite strong and it's disrupted the quality of life, right? Maybe you guys can consider kind of like the IV nutrition, you know, IV nutrition, you know, include both maybe partial parenteral nutrition, you know, and add in some micronutrients. I don't know, just sharing, you know. But again, you know, normally we want to see the data from the labs just to try to target it more than this one.
We have another question, Doc.
Yes, please.
Yes. Hi, Doc. I'm curious for a male, 32-year-old with very high DHEA, low testosterone. What possibilities do I need to check? He's very healthy, gym freak male. DHEA is 532 with the testosterone level is 13. Dr. Sebastian, if you will add anything else, you might unmute. You might want to unmute, please. Or probably waiting for your answer first, Doc. Thank you.
All right. I'm wondering that he take any what do you call amino acid supplementation or not, you know, or whether he take the hormone supplement, something that, you know, promote the hormone supplement or not, you know, because he is the healthy gym freaks, right? You know, if you take over supplement with some amino acids, sometimes it can promote overproduction of the adrenal hormone like this. But definitely, you know, when you have high productions of adrenal hormone and you don't have the balanced micronutrients, you know, some enzyme that converting this hormone might not work well. So I suggest that you may want to look at the size of micronutrient insufficiency in this case.
Yeah. Thank you, Doc. Yeah. Is there any other question about the concept, like the tree, the matrix? Anyone want to know more? Because that is actually the complex one. It takes me a long time and so many patients to be able to familiar myself with the tree and the matrix.
Yeah. But you work with, if you work with it every day, sometimes it becomes spontaneous.
Yeah. So and that is actually why I ask you, because I know that you're the expert, so it's just a lot better coming from you to the colleagues here.
Okay, Dr. Sebastian said that, okay, that guy take a protein shakes and 30 white egg every morning. So it's imbalance between macronutrients and micronutrients. You know, check the micronutrient status, I think. Okay, hope,
Doc-
you know, my
Doctor?
presentation can give some ideas about the functional medicine concept, right? You know, you know, my main emphasis is it's just a tool, it's just an approach. It's not a single treatment or a lab or kind of thing like that. You know, there are a lot of people say that, you know, they practice functional medicine and they, you know, invite people to do some treatment, thing like that. So that is not functional medicine.
Yes, exactly. Yep. That is what I want to emphasize too. This just the tool.
Okay.
At the end is the lifestyle, yeah, Doc?
Yep, lifestyle. But along the way, you can add in some supplement, you know, thing like that to help to support them along the recovery path.
Yes, yeah, I agree. Okay. There's another from Dr. Grace.
Yes. Dr. Sarah, would you like to read it?
No.
Okay. Okay. Hi, Doc. What is your suggestion for a patient who has succeeded lowering her HbA1c and glucose level with intermittent fasting, but still has high fasting insulin? I think this is alpha lipoic acid help, Doc? Thank you.
Single nutrient won't do any magics here. You know, high fasting insulin. You check at the cause of why your body have to produce that high insulin. You know, that is a sign of glucose intolerance, right? So insulin resistant. You know, inflammation. If you take the fasting insulin in the morning, check whether the sleep quality is good. You know, some people with chronic sleep disruptions come with you know, very high fasting insulin. So check the sleep qualities, or check whether are there any other underlying issues like chronic inflammations or chronic immune activation that might sustain the glucose intolerance there.
Dr. Grace, you might want to unmute. Is there any other questions?
Hi, Doc. Thank you for your answer, but I haven't asked her about her sleeping pattern, so I will ask her again. But she told me that she has done her intermittent fasting about for 3 months or 4 months, and she can lower her A1C, but she is still confused why her fasting insulin is still high. So she asked me. So I needed any suggestion from you. So I will sleeping pattern, and what else do you suggest I could ask her?
Check a simple marker for inflammation, something like you know, CRP or ESR, and if you can include some thyroid panels, right? You know, whether her thyroid panel is still working okay or not.
Okay, free T3 and free T4.
Yeah, and
right?
THS, right? Thyroid stimulating hormone.
Okay, I will do that. Thank you, Doc.
Okay, you're most welcome.
Thank you, Doc. For the other doctors, do we still have any other questions? Because I think it's already almost
6 o'clock.
Yeah. So
we're taking too much time off, Dr. Torsak.
I'm glad that we can share to the like mind. Okay. So, but thank you to have me.
Yeah, Doc. We hope that you would join us again one day with different topics.
All right. All right. No problem. Okay. Just shout.
Thank you.
Okay.
Yeah,
You're most welcome. Thank you, everyone, for joining.
Thank you very much, Doc. Have a good weekend.
You guys too.
Wait, Doc.
Yeah.
Yeah. Don't go. Can we take a picture together? So,
Yeah.
yeah. Can all of you
How can we take a picture? That is a problem now.
No, just stay there, Doc. Dr. Lisa will do the magic.
All right.
Everyone, please take up your video. Hitung dong. 1, 2, 3.
Satu, dua, udah semua ya? 1, 2, 3, 1, 2, 3, 1, 2, 3. Yap.
Thank you.
Terima kasih
Thank you.
semuanya.
Thank you, Dr. Torsak. Thank you, everyone. So see you
Thank
again.
Bye. Have a nice
Bye.
evening.
Bye-bye.
Thank you, Dr.
See you
Torsak.
next time.
Thank you, Dr. Sarah. Teresa.
Bye.
Thank you
Bye.
all.
See you next week.
Everyone.
Teresa.
Dok Sarah, thank you ya semuanya.
Oh, Bu Dewi, ya. See you next week ya.
Yes, see you next week.
Thank you.
Mbak Tika.
Iya, Mbak De, udah, dadah. Aku tadi takut salah soalnya namanya janjian sama. Yo, bye, makasih, thank you, see you.
Bye.
Dadah Sarah.
Daya dokter, kita tinggal berdua. Ada suaranya Dokter Lisa. Saya nggak dengar Dokter Lisa ngomong apa, nggak ada suaranya.
Kita masih ada 11 partisipan. Yes, you may leave.
Dokter Rani.
Dok, kita
Ya.
masih punya 11 partisipan. Should I end it?
Alhamdulillah.
Yes.
Alhamdulillah.
Oke, mau di end aja kali ya.
Thank you ya, dadah.
Dokter Sarah? Dokter Sarah masih ada? Enggak?
Udah nggak ada?
Udah nggak ada, oke. Bu Iin, karena ini saya tutup aja ya.
Ya.
Oke, thank you.
Makasih.
See you next time.
Bye,
Ya,
sukses.
bye-bye.